Grassley.
Thank you, Mr. Chairman, and thank you all for your testimony. Common sense supports all of us wanting to get more value out of our healthcare system. I was proud to lead the effort to implement Part D nationwide prescription drug benefits for seniors a long time ago. We used a market-based approach. Competition, access, and affordability has been key hallmark of Part D programs. And I think it, compared to what figures were given by CBO at that time, it turns out to be a good steward of taxpayers' dollars. In the first decade, saving 50% less than CBO projected. So, Dr. Merkel, what can we learn from Medicare Part D to apply to other federal health care programs?
Thank you for the question, Ranking Member Grassley. One of my key takeaways from Part D is there is often, especially with entitlements, perceived unnecessarily to be this tension between providing benefits and getting value for both beneficiaries and taxpayers. And I think Part D has been able to show that this tension does not need to exist. How did it do that? It mandated benefits, but it also required that financial risk be shared between taxpayers through Medicare, but also other entities, which are Part D plans. And very importantly, for accountability, the accountability of Part D plans is not just to the government or bureaucrats, but it's also to beneficiaries through choice. They can choose plans or switch plans if they're unsatisfied with the coverage options, and plans compete for beneficiaries. The result has been seeking high-value care. There has been high utilization of generic drugs. The United States has higher utilization of generic drugs than many of our international competitors. That's in part because of the way that Part D works. It's come in under budget, as you've noted, not just in the first decade, but as Dr. White noted, it's come in under budget again this most recent decade, and there's high beneficiary satisfaction.
Yeah. Dr. Merkel, or Dr. White, let me lead in with this about the Center for Medicare Innovation, Medicaid Innovation as well. Receives $10 billion of mandatory funding every decade. Despite this investment, CBO has found that CMMI has not lowered Medicare spending. Separately, CBO has found that Medicare shared savings program was not a factor in slower growth of federal health care spending. Are these models that I just referred to validated by independent third parties to determine if they saved money? And in addition to that question, if there are independent analysis, what do they say?
Thank you, Ranking Member Grassley, for the question. First, I want to clarify on CMMI, the CBO's conclusion was that it added on that to federal spending, and other researchers have come to the same conclusion, including Brad Smith, who's a former CMMI administrator. Health Management Associates did a study. Avalier did a study. So CBO's conclusion on CMMI is generally in line with the consensus. On MSSP, CBO's conclusion was that it appears to produce net savings, and the evidence is fairly clear from the early years of the program. The evidence is a little harder to interpret in more recent years, but that conclusion that the Medicare Shared Savings Program has produced small net budgetary savings is consistent with and partly based on what outside researchers have said. So I think when I said that CMMI and MSSP were not a factor in the slowdown, it's more to say that CMMI over the 2011 to 2020 period added a bit to federal health spending. MSSP had net savings together, they were not a factor in the fairly large slowdown during the 2011 to 2020 period.
Mr. Chairman.
Senator Van Hollen.